Rahmatullah. I'm Dr. رحاب المرسى, and today I'm talking about the auscultation. The intended learning objectives that we will cover today, inshallah, area of auscultation, final comment, equipment, infection prevention, procedure, type of breath sound, and I give you example of case studies. First, what are the area of auscultation that you have to examine? We have to examine the anterior chest, axilla, and the back. We use most of the chest, we will use the diaphragm of the stethoscope, which is the base of the stethoscope. Only we can use the bell in the area to auscultate the apex of the lung, because it has high pitched sound, which is the area above the clavicle. So the area of auscultation, site of the auscultation, we have the area apex, which is the area above the clavicle, then the infraclavicular area, then the mammary area, then the inframammary area, then the upper axillary area, then the lower axillary area. As you notice here, the examiner first pose the stethoscope in the here, for example, in the mammary area right, then move to the left mammary area. So don't auscultate the left, right, and after finishing the right, moving to the left. No, every area you should compare it to the same area on the opposite side. On the back, you ask the patient to sit down and examine the back. We divide the back into two major areas, the interscapular areas and the infrascapular areas. So what's your final comment? Type of breath sound, in intensity, the equality on both sides, if there is added sound or no, and the vocal resonance. And finally, example, I auscultated bilateral vesicular breath sound with diminished intensity on the right infrascapular area with no added sound. Another example, I have auscultated bilateral vesicular breath sound with prolonged expiration and expiratory with this equal on both sides. What is the equipment? You use the stethoscope. The ear tips should be directed forward in your ear, directed towards the nose. And as I said, most of our work will be the diaphragm, but we use only the bell to auscultate the apex of the lung above the clavicle. The stethoscope can be an equipment leading to transmission of microorganisms between the patients, so it have to be cleaned between every patient by wiping it with alcohol. It is advised to have your stethoscope for your ear, because there is a risk of transmission of infection, and maintaining clean ear tips can be difficult. Not necessary to use non-sterile gloves. Nurse have to assess if the stethoscope have been contaminated by blood and body fluids. For example, if patient coming in traffic car accident, maybe the stethoscope contaminated with blood or any body fluids, so it should be cleaned. In COVID, the stethoscope represent an equipment with high risk of transmission of infection between patients, so it should be disregarded and not used to a great extent, except if you notice that patient become desaturated, means saturation is dropping, and you are worried that the patient have a pneumothorax and you want to manage him. So to auscultate your patient, you have to be in quiet area to appreciate what you hear and interpret your finding. You have to expose the close of your hand, close of your patient, so you have to keep the patient in a place ensuring his privacy and his dignity. So what is the procedure? Again, ensure that your scope is cleaned. Discuss the procedure with the patient and gain informed consent. For example, I'm a Dr. رحاب. Can I auscultate your chest, please? Check that the patient is kept warm and the area is free from draft. Especially if your exam always it is a January, so the there is cold weather, so you have to ask the patient if there is if you feel cold, or is it okay for you to expose your clothes. Ensure that the patient maintaining your patient privacy and dignity. You have to pull the curtain so the patient not seen by other people. Decontaminate your hands. Position the patient comfortably. You can ask the patient to sit, or always we ask the patient to examine his the anterior chest. We ask the patient to lie flat. Remove his clothes so you can expose all the chest. Warm your stethoscope before putting it in the patient. Position the ear tips as I said so they slightly forward towards the nose. Holding the stethoscope between the index and middle finger of your dominant hand with gentle pressure on chest. Step ladder approach اللي هي comparison. Right supraclavicular area, left supraclavicular area, left infraclavicular area, right infraclavicular area, right memory area, left memory area, right left inframemory area, right inframemory area, left inframemory area, right inframemory area, left inframemory area. And don't forget to ask the patient to move their right arm to the side so the right lateral chest can be assessed. The axilla, don't forget it. يبقى ال upper axillary area, left upper axillary area, left lower axillary area, right lower axillary area. And the same, don't forget the posterior chest. Posterior chest we have the اللي هو above the scapular area, above the scapular, interscapular area, اللي هو suprascapular area, right starting with the right, then left intrascapular area, upper right intrascapular area, lower interscapular area left, right intrascapular area, infrascapular area, right left, then left right. Not necessary to examine the scapula because the breath sound will not be clear. Ask the patient that if you have any questions, decontaminate your hand and your stethoscope. Interpret record the finding in your notes and explain your finding to the patient that you okay. You need further investigation like X-ray or CT. We need to do follow-up. It's nothing for you, but you are okay, and we have to. I have to see you again within 1 week or within 3 days, whatever the conditions. So again, in the mark list, marks on introducing yourself to your patient, taking a consent from him oral that you will examine him, asking the patient what's your name, what's his name, warm your hands and your stethoscope before touching the patient, asking the patient if you feel warm or you cold, that you have to assure that the patient is comfortable while you examining him. Then expose the patient to clothes. Don't auscultate your patient while he wear his clothes. He should be exposed. Please the patient asking the patient to lying down to examine the anterior chest, and then raise his right and left hand away to examine the axilla, and don't forget to examine the back by asking the patient to sit using the step ladder approach. That means that don't examine the right side and after examining the right side moving to the left side. You have to examine it by comparison, right left, then left right, till you covered all the chest areas. After finishing, you have to replace the patient clothes, thank him, explain what you have found. It's normal. There is some wheeze, and inshallah it will go with treatment. I have to do further investigations. It's okay, but I have to do follow up and decontaminate your stethoscope and your hands. Important note: the diaphragm of the stethoscope that should be used. Ask the patient to take a deep breath in and through his mouth. If you didn't ask the patient to do this, you will lose mark. So it's very important to ask the patient to take a deep breath from his mouth in and out. Would you please, if each time I move the stethoscope, please take a breath from your mouth. Listen to both inspiration and expiration. Inspiration while chest go out, and expiration while chest go in. If you found an abnormality, you have to define what is the area that you find the abnormality. If it is here, I found abnormality in the right inframammary, here in the left infrascapular. If you notice added sound, you have to define, I found it in inspiration or expiration or both. Type of breath sound: we have basic breath sounds, we have adventitious sounds, and we have vocal resonance. Basic breath sounds, we have three types: vesicular, bronchial, bronchovesicular. This slide is the normal, that you normally will hear the bronchial breath sound in the neck till the manubrium sternal, and in the back till the second thoracic spine. Normally you will hear the bronchovesicular breath sound in the first and the second intercostal space في البارasternal area, and also in the back في الفيرست and second intercostal space في paravertebral areas. And all the other area of the chest you will hear normally vesicular breath sound. In added sound, we have what's called the crackles, wheezes, and the pleural rap, and the vocal resonance. So what is the breath sound? Breath sound in basic vesicular, it is normal. What's mean by normal means that when you put your stethoscope in any area of your chest, you will hear it. So please put your stethoscope in your mammary area and take a deep breath from your mouth in and out. You notice air movement. So it is generated by airflow through the airways, and this airflow transmitted through the alveoli. What is the function of the alveoli? It is filtration of the high frequency sound, allowing only the low frequency sound to pass. So this gives you the low pitched sound. It is heard in inspiration and early expiration, ratio 3:1. Why? Because the 2/3 of expiration, the frequency of sound is too low that you cannot auscultate it. It may be diminished, reduced if it is in the right side only or left side only. You have local cause like effusion, tumor, pneumothorax, pneumonia, lung collapse. If it is diffuse in both sides, you have silent chest like asthma or COPD, or patient is obese, fatty. So this is the example of vesicular breath sound. It is low pitched sound, rustling sound. It is called vesicular because it is, as I said, generated by passage of air through the airways, and the transmission by the vesicles. What is the vesicles? The alveoli. And what is the function of the alveoli? Again, filtration of the high frequency sound, allowing only the low frequency sound to be passed. There is no gap between inspiration and expiration. The expiration is only 1/3 of inspiration. This is an example of diminished vesicular breath sound. It may be auscultated over the chest, which is the muffled breath sound, pathognomonic for the emphysema. What's meant by muffled breath sound? When you ask the patient to increase the intensity of his sound, the sound will not magnify in your stethoscope. May be localized, like patient with right side pneumothorax, where you find diminished intensity of breath sound on all the right side. Patient with left-sided pleural effusion may find diminished breath sound in the left infrascapular area, upper and lower. Patient with right middle lobe collapse, you may be find diminished intensity of breath sound on the right inframammary area. Now we will talking about the bronchial breathing. Bronchial breathing, it is a sound generated by passage of air or flow of air in the airways and pass any changes to the stethoscope. Means that we have lost the alveoli due to consolidation, the replacement of the air in the alveoli by exudate and fluid, or the alveoli become collapsed due to compression, collapsed with patent bronchus, compression from outside, like an upper border of the effusion, or we have a mass with compressing on extraluminal compression of the bronchus, leading to collapse. So bronchial breathing caused by increased density of the matter in the peripheral lung means that instead of filling the alveoli with air, it is now devoid of air, filled with exudate from infection or collapse. But the collapse should be associated with a patent bronchus. Why patent bronchus? Because if I have endoluminal obstruction by tumor or foreign body, so no airflow in this area, this lead to diminished breath sound. So if I have a collapse with patent bronchus, this will give bronchial breathing. If I have a collapse with obstructed bronchial due to tumor or foreign body, I will have diminished intensity. So the sound passed from the larynx to the stethoscope and it changes both the high frequency and the low frequency sound. It is a hollow sound, blowing inspiration equal to the expiration with a brief pause in between. A similar sound can be heard over the trachea. You can put your stethoscope on the trachea and take a deep breath, and you will hear hollow sound with inspiration equal to the expiration with a gap in between. Why? Because here the sound passes on the trachea and no alveoli here. Is there is alveoli connected to the trachea? No. So the criteria of the sound will be bronchial breath sound. Sound passing from the movement of the vocal cord to the stethoscope and change it. So the bronchial breathing is heard over the consolidation, lung abscess, and at the upper border of the pleural effusion, and collapse with patent bronchus. So you notice here it is a hollow sound. In inspiration equal to the expiration and with small gap in between. The third type of the basic breath sound is called bronchovesicular breath sound. In the bronchovesicular breath sound, both inspiration and expiration are equal. You normally hear it in the mid-chest area, in the first and second intercostal space anteriorly parasternally, and in the posterior chest في first and second intercostal space between the scapula. As I said, it is a mixture of bronchial breath sound in which the inspiration equal to the expiration, but there is no gap in between. It is here near the trachea and with minimal surrounding alveoli. So this is the bronchovesicular breath sound, hollow, inspiration equal to the expiration but with no gap in between. We're moving now to the added sound, starting with the wheezes. It is a continuous musical whistling sound caused by narrowed airway. It is hard, easier in expiration. If you have a disease affection, different airways, large or small airways, this will give you polyphonic wheeze, of course associated with prolonged expiration. If you have a single airway narrowing due to local cause like foreign bronchial carcinoma, you will have monophonic wheeze. As I said, it is not a good marker of disease severity because silent chest, it is in the index of life-threatening asthma or COPD. So it is a vesicular breath sound with prolonged expiration and expiratory wheezes. This is called monophonic wheeze due to airway obstruction by foreign body or tumor. And by the way, in the exam it is not necessary to differentiate between monophasic or polyphonic wheeze, just to say this is wheeze. This is also bilateral vesicular breath sound with prolonged expiration. We have inspiratory and expiratory wheeze. Moving to the second added sound, which is the stridor. Stridor is caused by upper airway obstruction. We're talking about obstruction at the level of the larynx by tumor or paralyzed both vocal cords or the trachea. It is often heard without stethoscope. It is loud, high-pitching, crowned breath sound here during respiration, but may also occur throughout the respiratory cycle as the patient worsens. Stridor in children become louder in the supine position. Causes may be pertussis infection, croup, epiglottis, aspiration, obstructing the larynx. And it is an emergency. If you're dealing with such case in a child, you may give him a chance of nebulization with adrenaline. If no improvement, should be referred for tracheostomy. If I have obstruction at the trachea, do you think that the tracheostomy will help the patient? The tracheostomy is incision at the level of the larynx, and now we have the obstruction below the larynx. So if you do tracheostomy, you will do nothing for the patient. Say the patient have stridor and have suffocation. So the treatment here, if you have endobronchial lesion, either you excise it or excise it surgically, or do the debulking of the tumor by laser or electrocautery, or if you have extraluminal obstruction, you can insert a stent through the rigid bronchoscopy. So crackles, this is the second added sound. It is caused by air entering collapsed airway and alveoli producing opening snap. It is heard inspiration, non-continuous. Coarse crackles are made by large airway opening, and fine crackles made by small airway opening. Examples: pneumonia, atelectasis is a collapse, pulmonary fibrosis, bronchiectasis, acute respiratory distress syndrome, interstitial lung disease, pulmonary edema secondary to congestive heart failure. The fine crackles in interstitial pulmonary fibrosis is called velcro crackles. The sound produced while trying to gently separate the joint strip of velcro adhesive present on the blood pressure cuff. Early inspiratory and expiratory crackles, it is characteristic of chronic bronchitis. You can hear late inspiratory crackles at the lung base. It is not significant, because if you ask the patient to cough or change his position or several deep breaths, it disappears. That may be normal fine. So this is an example of pan-inspiratory coarse crepitations. As I said, it may be due to pulmonary edema or bronchiectasis. This is an example of velcro crepitation. It resembles, as I said, rubbing cellophane papers, and it is present in characteristic or pulmonary fibrosis. This is an example of early inspiratory crackles, which is pathognomonic for COPD. This is an example of late inspiratory crackles. It is not. It hasn't characteristic. It has it is not. It has no characteristic sign, and can disappear if you ask the patient to cough or take deep breath or change his posture, and it is normal finding, needed no further investigation. Continual added sound. We now talking about the pleural rub. Pleural rub, it is described as rubbering laser. Coughing will not alter the sound, and it is produced because the two inflamed surface of the pleura, parietal viscera, are sliding by one another. During auscultation, pleural rub can be localized to a particular place in chest wall. They sometimes come and go. Common causal pneumonia and pulmonary embolism with infarction. Because this sound occurs whenever the patient's chest wall moves, they appear on inspiration and expiration. The rub stop when the patient holds his breath. If it is continuous, so you auscultating precardial friction rub. It is heard in the late inspiration and early expiration. This is the pleural rub. It is heard in the late inspiration and early expiration, and it doesn't disappear if you ask the patient to cough or take several breaths, and that you will find it localized to a certain place in the chest wall. Moving to the vocal resonance. Here the added sound and the basic breath sound, the patient have to take a deep breath from his mouth to auscultate the patient. While here it is like vocal fremitus, the patient must speak say 99 or 44 يبقى it is the sound transmitted by the vibration of the vocal cords, and the same it have the same causes as the vocal phlegmatis. We have three types of vocal resonance: egophony, bronchophony, and whispering bacteriology, and we'll take each one by details. What is the whispering bacteriology? The whispering bacteriology, I ask the patient to whisper 99 like this. Say, I ask the patient every time I move the stethoscope, please say 99 in whisper manner, like that. 99, 99. Or sometime 1, 2, 3. 1, 2, 3, 1, 2, 3, 1, 2, 3. The lung area is abnormal if 99 sound is understood, means that you auscultated clear. If the and this whispered can be cleared here, this is the termed whispered bacteriology. If you cannot understand it, يعني when the patient say whisper 99 and you auscultate him, you cannot the sound is understood, this is normal lung. Here an example, I auscultate the patient and I asked him to say 99 in whispered manner, 99, 99. But when I auscultate him, I cannot understand, I cannot hear the spoken voice clear. So this is a normal. Moving to the bronchophony, the second type of vocal resonance, I ask the patient to say 99 while auscultating chest wall or 44. Over the healthy lung area, the 99 sound is not understandable, while over the consolidated area it is understandable because the consolidated area allow better sound transmission, because I said before the alveoli prevent the transmission of high frequency sound. So if I have a consolidation, so the high frequency sound will pass by leading to better sound transmission. In this example, I asked the patient to say 1, 2, 3 and you auscultate it clear. The last type of the vocal resonance is called the egophony. Egophony is a sound with nasal quality, and it is also it is have a higher intensity over the abnormal lung area. I ask the patient to say E several times. I auscultate the chest. Over the consolidated lung area, the sound will be auscultated as A. Over the health lung area, the sound is auscultated as E. But what is the mechanism? The vowel E has a low frequency in the range of 100 to 200 Hertz, as compared to the low frequency of A, which may reach up to 6 Hertz. The E also consists of high frequency from 2000 to 3500. So consolidation creates a dense media that facilitates the transmission of the lower frequencies. So patient with underlying consolidation, the E is transformed into A. In case of pleural effusion, the fluid accumulates in the pleural space. The fluid compresses the underlying lung parenchyma, make it more solid. This leads to alteration of the lung acoustic, transmits the high sound frequency and give rise to egophony. So the egophony is heard over the upper border of the effusion. polygophony A. This means that I asked the patient to see E, and over the consolidated area or the upper border of the effusion, I auscultated it as E. I asked the patient, I asked the patient to say A, to say E. I asked him to say E. Every time I move the stethoscope, please say E. Over the abnormal area, like consolidation or upper part of the effusion, I auscultated as A. So A, it is positive gophony. While here it is the normal. So when I ask the patient to say E, normally I auscultated it as E over the healthy lung tissue. This is a dispense sign. It is a special sign, auscultatory sign. It is a bronchial bracing over the vertebral body below the level of the tracheal bifurcation, which is below the second thoracic spine in adult, if there is subcarinal mediastinal lymphadenopathy. Here example of case studies. Emma Green, aged 65, attends the emergency department with a history of productive cough for 5 days, reduced exercise tolerance, and increased breathlessness. She reported pain on the right lower aspect of the posterior chest. On assessment, Miss Green reported no underlying respiratory disease. Chest auscultation identified reduced air entry in the right lower lobe and additional coarse crackles in inspiration the right mid-zone. So what's your differential diagnosis? Decreased air entry. What is the differential diagnosis of decreased air entry? Maybe pleural effusion, maybe collapse, maybe mass, maybe pneumothorax. But what is the differential diagnosis of crackles? Maybe infection, maybe just infection, maybe but here it is more with infection, because if it is pulmonary edema, it will be diffuse and bilateral. So this history suggests diagnosis of pneumonia and may be associated with parapneumonic effusion. Second case, Gaber, gravid, aged 45, admitted to GP with increased breathlessness and audible wheeze. He recently started treatment of asthma. His symptoms present for 24 hours and has been using salbutamol inhaler but remain asymptomatic. Her personalized asthma action plan suggests that he should visit his GP. On assessment, Mr. Garpet was using accessory muscles to brace and was pale. He was only able to complete short sentence and was breathless at rest. Chest auscultation revealed inspiration and expiratory wheeze in all lung field on the left and right side. So this is acute exacerbation of asthma, right?
This time, James, every time I place my stethoscope on the chest, could you say 99 for me?
99, 99, 99, 99, 99, 99, 99, 99, 99, 99.
James, if you could now sit forward. Just keep your arms folded and breathe in and out through your mouth for me. Now if you could say 99 for me.
99, 99, 99, 99, 99, 99, 99, 99.
If you meet a station of auscultation inshallah on the OSC exam revision, introduce yourself to the patient, take from him oral consent to auscultate him, warm your hand and your stethoscope and clean it before, by rubbing it with alcohol. Expose the clothes of your patient. Start with right supraclavicular area, then shift to the left, then left infraclavicular area, then right, then right mammary area, then left, then left inframammary area, then right. Then ask the patient to raise his arm aside, the right arm aside, to auscultate the right upper axillary area, then left upper axillary area, left lower axillary, then right, then asking the patient to sit down and auscultate the suprascapular area, right, then left, then the intrascapular area, upper right, left upper interscapular area, then right lower interscapular area, then left, then left right upper infrascapular area, then right, then lastly right lower infrascapular area to the left. Then thank your patient and replace his clothes and tell him that you're finding that you normal, or you auscultate some wheezes that will go with treatment, or you auscultate, you are worried that you may have infection, you have to do further investigation by chest x-ray, or is it okay and we'll just do follow up within 1 week. Then tell the examiner your finding, never tell your examiner that the patient have wheezes or crepitation. You have to follow the scheme. First, the type of breath sound. So the type of breath sound, like this patient. This patient have a pneumonia in the upper lobe. So you may find bronchial breath sound over the right infraclavicular and the mammary area with inspiratory crepitation and in the vocal resonance you may find bronchophony and whispering bacteriology with a egophony on the affected site. A egophony. Normally when you ask the patient to say E, you will auscultate it E, but if the patient have consolidation, the E will be transforming into A. The patient, this type of patient may have vesicular breath sound with inspiratory crepitation. If case of this patient pneumothorax, you will find bilateral vesicular breath sound, but we have diminished intensity on the right side, all the right side, just the anterior and the back. Maybe the patient with pleural effusion, you have bilateral vesicular breath sound with no added sound, but you have diminished intensity on the right infrascapular area. Okay, in the collapse, if it is collapse with obstructive bronchus, you will find diminished breath sound. If it is with patent bronchus, you will find bronchial breathing sound. In this patient with pleural thickening, you will find also the breath sound with diminished intensity. You have first to comment on the type of breath sound. It is vesicular or bronchial. Intensity, is it equal on both sides or diminished? والemphysema. In emphysema, what is meant by muffled breath sound? It means diminished intensity. That means when you ask the patient to take a deep breath, the intensity of the sound will not be intensified on the stethoscope. You have to comment on the added sound. Is it wheezes, crepitation, and is it heard in inspiration or expiration or both? And you have to comment on the vocal resonance. Is it equal on both sides, reduced? Is it positive? Means that you have positive bronchophony, egophony, or whispering bacteriology. And that's it. Thank you all.